You all know the aortic regurgitation, leakage of blood from the aorta back into the left ventricle during the diastole because of the failure of the aortic valve to close properly. And it's also called as aortic incompetence. There is nothing new in that. But aortic regurgitation can be caused either from the primary abnormality or the valve. And usually the AR is due to the inadequate coaptation. But what I'm going to show today is not into the LV, but the RV. So this happens whenever, I think today Satish is going to show you how to quantify the aortic regurgitation. But when this happens into the right ventricle, it becomes very difficult. This is a 10 years old boy operated from the West Bengal. And then he presented with a history of easy fatigability, generalized edema in NYHA class 4 and for the past 6 months. The heart rate was 150, high volume collapsing pulse. The BP was 136 by 0 to 40. JVP was raised, prominent A wave present, and resting saturation was 94. And this is how he presented with congestive cardiac failure post-operatively in a tetralogy of Fallot. So in tetralogy of Fallot, failure is not a usual feature. Very rarely they can develop failure due to the anemia, associated PDA, or large MAP cause, multiple MAP cause, or infective endocarditis, or hypertension in a grown-up tetralogy, or the pulmonary regurgitation, or the adult top, but with the RV dysfunction. But prolapse of the aortic cusp is usually does not occur because we think that there is no support to the aortic valve, but it can happen up to 20%. So how many of you have seen anything like this? Please raise your hand. None, isn't it? So here is the patch. The VST patch is closed and you see two jets, one on the RV side, bigger jet, and one on the LV side. That means the overriding aorta which was there, that is not brought completely into the LV. So part of it cusp is remaining in the RV side and part of it on the LV side, and that overriding is still there. Now it is straddling on the patch that is there. And as a result, this is the iatrogenic aortic regurgitation which is occurring into the right ventricle. So when the aortic regurgitation occurs in the right ventricle, all the congestive cardiac failure features are there. So whatever we teach clinically, you have to correlate. So measurement of the aortic regurgitation here, it becomes very difficult because you cannot measure into the LVOT, the ratio to the jet, or the vena contracta cannot be measured because it is split into vena contracta into two halves. And that's how this is very difficult. So the patient was operated, the aorta was brought back, and the aortic cusp was repaired. And then after 1 month, he came back with the fever and breathlessness. So this is the sad part in our Indian subcontinent. We try to help the patient and ultimately they succumb to the bacterial endocarditis. Now you can see that a huge vegetation on the patch. So aortic regurgitation has gone, but there is a vegetation on the top. And this is how the child came back with the, again, thing. So now we move on to the second case. This is a 52 years old patient presented with the history of palpitation since childhood, fatigue for past 1 year, dyspnea for 1 year. I'm showing this to make you realize that we say small VST, leave it alone, but then ultimately look what happens. Now there are two jets. One jet is on the LV side and other jet on the RV side. So there again two split. Now how can the split thing can occur in such a patient? Actually, this is a small VST which was not closed. And now what has happened is non-coronary cusp is prolapsing into the RV and it is trying to close the VST. So the VST is closed at the cost of cusp prolapse, and the cusp is prolapsing so much into the RV that the jet is also going into the right ventricle. So that is the what you say that consequence of not closing the small VST. So this picture is from my textbook. Many of you might be reading that book, Comprehensive Approach to Congenital Disease. Now you see that when the cusp prolapse is there, because of the Venturi effect, when there is a small VST Venturi effect, the cusp will be sucked into the RV. So when the cusp is more into the RV, the co-opting point also come into the RV, and that's how you get the regurgitation in the RV. So carry home message is aortic regurgitation into the right ventricle is extremely rare. It could be due to the surgical mishandling, extreme degree of aortic cusp prolapse, or clinical examination combined with the 2D echo with the color Doppler can make the precise diagnosis so that the correction can be done timely. And hence, one should know the best physician is the one who is able to distinguish between the possible and the impossible. It is possible to correct when the regurgitation is occurring into the right ventricle. Thank you very much for your kind and patient hearing. Thank you.